Thanks for that introduction, and thank you, the organizers, for inviting me to come out. So I was telling a few of my colleagues yesterday, some of my referring colleagues, that I was going to come out and talk about the flavors of radiation, and they kind of rolled their eyes, and they said, that doesn't sound very exciting, and it reminded me of a story. So I grew up in Texas, and so I'm a big fan of Lyndon Baines Johnson, and so there's a story of LBJ, and he was talking to a healthcare economist. The healthcare economist was going on and on about all the great things that were happening in, his world, and why this was so amazing that, when Medicare and Medicaid were coming out back 50 years ago. And LBJ just kind of stood there and listened to him for about 10, 15 minutes, drone on and on and on. And so the healthcare economist at the end of it says, well, you're not saying anything. What do you think about this? And so LBJ kind of turned to him very sternly and very quietly and said, everything you've said is kind of like pissing on your leg. And the healthcare economist was kind of like shocked. And he was like, this is the president of the United States talking about pissing on your leg. And so he said, LBJ responded, he's like, it's really hot to you, but not to anybody else. So hopefully this conversation that I have with you is actually going to be inspiring and hot, because I do think that radiation therapy has some really exciting things that we can kind of talk about. And I think there's a lot of new things that we have some new tools in our tool chest to kind of use. So let's see if this works. I don't have any disclosures. Kind of a roadmap of what I'd like to talk about today is just talk a little bit about the flavors of radiation therapy, just briefly talk about the role of radiation therapy. I know Dr. Lee is going to be talking about that in a little bit. Briefly touch on conventional radiation therapy and IMRT, and then talk about proton and neutron therapy. So let's start by talking about the flavors of radiation therapy. This isn't Baskin-Robbins. We don't have 31 different flavors, but we do have a few that we can kind of choose from, and hopefully a combination of these will lead to the appropriate treatment for our patients. I think ultimately it comes down to not only choosing the right tools for this, but also choosing the appropriate patients. So just brief, because I know not everybody in this room is a radiation oncologist. There's lots and lots of different types of therapeutic radiation therapy. Photons is the most common type that we use. It's generated by a linear accelerator. There's different energies that allow for different depths of penetration. Electrons, are particles themselves. They aren't these invisible kind of X-rays. They're generated by a linear accelerator that tend to be more superficial and sharper dose fall-off. Typically with conventional radiation therapy, we're going to use a combination of photons and electrons. Electrons are going to be used over more sensitive areas like the heart, the spine, et cetera, if we want to get to high doses if we're using conventional radiation therapy. Other types, there's neutron radiation therapy. That's generated by a cyclotron. Our cyclotron at the University of Washington is about four stories beneath the earth. It's beneath the medical center. It's about the size of a football field. It causes more direct damage to the DNA. And then there's also protons, which we've added a proton facility a couple years ago now. And that's also a particle. It's generated by a cyclotron, smaller than our one at the Neutron facility, but definitely a significant size as well. And there's a sharper dose fall-off, and I'll kind of talk about a few of those characteristics in a second. So the way it kind of, I feel like a good analogy when I kind of try and explain this to people is, electrons are kind of like a little kind of water gun, little pistol, where it's going to do a little bit of damage in that area. Protons and photons are going to be kind of like your super soaker. It's going to come in and do some double-stranded breaks. And then your neutrons are going to be like your cannon. You don't give a lot of dose of it. You really, you end up giving about 3 weeks of therapy at the end of the day. But it does lots of damage, and it has a very high effect. So kind of to give you a schematic of what we're talking about when we look at this, and let's see if this pointer works, there we go. Your electrons are gonna be this very superficial area like I talked about. Your protons are gonna kind of come out here, and they're gonna do their damage a little bit farther down, and so it has its role, because obviously sometimes patients are gonna need that. And then neutrons are gonna have a little bit high of energy, and then photons are gonna be kind of your traditional radiation therapy. So looking at this, just again, emphasizing a little bit about photon therapy. People don't really understand it. It's kind of like it ends up getting a little bit hotter over the area that you want to, before you get to the area you want to treat. I like to use the analogy of like grilling. Again, growing up in Texas, we did a lot of that. It's kind of like your steaks right here, and obviously to get the heat to the area of the tumor, you're going to have a little bit of a higher heat in front of it. And so obviously we take advantage of the fact that we use multiple beams and multiple angles, so you're not essentially having a very high hotspot in front of the tumor, and that would only happen if you were just using one beam. So proton therapy takes kind of advantage of the fact that it's a particle and it kind of accelerates, and then it's going to deposit its damage here. So let's say there's a tumor that sits right here, as compared to a photon radiation beam, which kind of comes in, does its damage, and then kind of falls off. Like any X-ray, a proton beam is going to come in, do its damage here, and then have a fall off over there. So kind of comparing the two, you can see that we now have this spread out Bragg peak, and so you can deliver your radiation dose to a specific dose that you wanted to get to, and for critical structures that sit behind it, like say a heart or other structures, you can kind of avoid that area as well. So there's some benefits potentially to proton therapy, but I would say that's very, very early at this point. So kind of to illustrate what I talk about when I'm talking about proton therapy compared to photons, so let's say a radiation beam comes in from this side. Like I said, it's going to be a little hotter up front just because you want to get the dose to the middle of the tumor, and this is obviously just using one beam. With proton therapy, you kind of come in, you deliver your dose, and then there's very little fall off on the other side of it. There is some range uncertainty that I think people are still trying to figure out, and so I think there is quite a bit of work that still needs to be done before we kind of say, oh yeah, this is the end-all be-all for every single tumor out there. Kind of to give you another schematic, when you compare 3D conformal radiation therapy, where we kind of deliver the dose from both sides to, let's say, a brain region, intensity modular radiation therapy allows us to kind of carve that dose out so that we're not treating some more critical structures in that arena. Protons kind of can do the same thing, and actually, since the dose fall off is smaller, you're going to have less of this kind of low dose that goes into other parts of the body. So it does have a role, and I think that kind of makes sense. And to kind of talk about the excess dose that's given, this is a patient that got craniospinal radiation. So this is the dose that you would give with proton therapy. You can see that it's very hot in the areas that we want to treat the cranium and the spine. With photon therapy, you still treat the cranium and the spine, but there is a little bit of low dose that comes out on the other side. And so if you take the proton, you subtract out the photon therapy, this is all the excess dose that you're able to save by treating with proton therapy. So in certain cases, like this is a pediatric patient with craniospinal radiation, it makes a lot of sense to give proton therapy. But in other cases, maybe in mesothelioma or other ones, we're still trying to figure that out. And I'll get to that at the end of the talk. So those are kind of our, and this is just one more illustration kind of looking at it where you can kind of, again, save lots of dose, say, out back. This is a patient that we treated with thymoma, where you're treating in the area up front, a lymphoma, where we were able to treat the areas up front, but able to avoid the areas out back. Neutron therapy, just to kind of touch on that, this is a picture of our unit right here. It's pretty ginormous. It's about 2 stories in height, and actually when it rotates around, the floor kind of comes out. The patient kind of sits and floats in this kind of little chair area. It's very high energy transfer, increased energy deposition in the tissues. We commonly use it in adenoid cystic carcinomas just because there's a randomized study that shows that there's a benefit in the patient population in salivary gland tumors, and also in some radio-resistant tumors, including sarcomas and melanomas. We have tried it in mesothelioma, and I'll kind of get to that again towards the end of the talk. And the way it's been around for about 40 years, so everything is kind of these old consoles that we're using in terms of kind of making sure that it works, but it's very reliable and has been around for many, many years to be able to treat patients effectively. The way neutrons work, just to kind of explain that, since we've talked about protons and photons, the neutron comes into the interior atom. It's going to have a recoil proton that's going to go and do some damage, and also a neutron of reduced energy that can either do damage itself, or it can go into another atom and then create another proton. And that's why the relatively biologic effectiveness dose is actually much higher. This rationale is, ultimately when we use neutron therapy, it's better able to kill hypoxic tumor cells. The oxygen enhancement ratio is about 1.6, so it makes it a little bit more enhancing. Cells are less able to repair the radiation damage, often because we're able to kind of shear that DNA, and there's more double-strand breaks. There's definitely more sublethal damage and potentially more lethal damage depending on what energy you end up using. And there's also less variation in radiosensitivity across the cell cycle. We know that photon radiation therapy, there's certain parts of the cell cycle that are very effective. With neutrons, because it kind of destroys without, it's a cannon, it doesn't really have a lot of specificity. It just kind of destroys everything in its path. This is kind of the relatively biologic effectiveness data out there. And we know that when we do this, the therapeutic, it's about 8 times as effective as photon radiation therapy is what we've kind of determined when we've kind of looked at this. In late tissues, we've seen like in, say, the spinal cord, it ends up having about a threefold increase. And so we typically don't treat more than, say, 10 or 11 neutron gray to the spine because you're giving it essentially in 3 gray fractions. But we are able to deliver a very high dose if you look at it compared to effectively to a photon therapy. So the ways that we kind of look at in summary in terms of the methods of improving tumor control, there's lots of ways that you can look at dose distribution and use conformal or interop or brachytherapy or stereotactic to kind of influence that dose distribution to improve tumor control. Proton beam and alpha particles are very helpful in doing that. Or you could also take advantage of the tumor biology. And so, a lot of things like hyperthermia or hypoxic sensitizers are going to take advantage of the tumor biology. Neutron beam, we feel like, takes advantage of that tumor biology and that radioresistance because you're not waiting for the cells to cycle through. We're trying to get more direct damage. And so, because of that, for those tumors that are radioresistant, like I said, sarcomas and maybe mesothelioma kind of fits in that category occasionally, we tend to consider using neutron therapy. So in general, and I won't go too far into this because I know other speakers have kind of talked about this a little bit, what's the role of radiation therapy in the treatment of mesothelioma? We know that the NCCN has kind of said that you can use hemithoracic radiation in the resectable setting as well as with pleurectomy and decortication. They're saying chemotherapy. They typically don't advise using radiation therapy in that. Extrapleural pneumonectomy, though, again, you're going to use sequential chemotherapy and hemithoracic in both the resectable setting. So for post-EPP patients with good performance status, adjuvant RT can be used to improve local control. The NCCN has not stratified based on histology, which I think we may eventually get to in terms of only treating certain histologies, like just treating epithelioid. You can use it to treat seated instrument track sites. We don't at the University of Washington. I think there's studies on both sides to do that. It's useful for palliation of chest pain or METs. With no resection, high-dose XRT has not been shown to improve survival, and toxicity is very high. We don't do that when there's no surgical intervention. RT is usually not recommended and can be considered with caution under strict dose constraints or in a clinical trial only. So what is the data that's supporting the use of conventional RT in the adjuvant setting? And I think, all of us kind of quote this study. You've heard most speakers that have been up here kind of talked about Valerie Ruch's study that was published in 2001. The phase 2 study, 88 patients. Most patients got EPP, about an 8% post-op mortality. A good chunk of them actually got post-op radiation therapy, 57 patients, 54 of those that had EPPs. Your median survival was about 33.8 months for stage 1 and 2, and only 10 months for stage 3 and 4. Only 7 local recurrences and only 2 isolated local recurrences. So, a lot of people surmise from this that, radiation therapy obviously is decreasing that local recurrence rate, and so we should continue to use it. There is a study also that is a phase 2 study, the URTC study, that a couple people have also mentioned. It's a trimodality therapy looking at malignant pleural mesothelioma. They use cis and PEM for 3 cycles, then EPP, and then radiation therapy to 54 gray and 30 fractions. Their primary endpoint was the success of treatment, and the secondary endpoints were toxicity and overall and progression-free survival. They found that the median age was about 57 years. A good number of the patients were actually very early T1s, 36. Only 6 patients were actually T3s. Most were actually N0 patients. 55 of those patients, so vast majority, received 3 cycles of chemotherapy. The 46 went on to receive surgery, and 42 had EPPs of those. The 90-day mortality was about 6.5%. Post-op radiation therapy was completed in 37 weeks after 37 of those patients. The grade 3 and 4 toxicity persisted after 90 days in just 3 of those patients, so patients were able to recover. Their overall survival time was about 18.4 months. I think that's kind of an important number to kind of keep in mind, and I'll kind of summarize all these at the very end of this talk. But we're really not going much beyond 2 years, I would say, for all of these median overall survival times. Your progression-free survival is about 14 months. And so in those patients, local recurrence was about 16% of patients who completed the therapy. So what's the data that's used to support IMRT in the adjuvant setting? Well, and does conventional radiation therapy actually miss targets? And can you use it in the fluorectomy decortication setting? I think those are all good questions that I've gotten from a number of my trainees as well as referring physicians. And so the study that I think a lot of people quote is the one from MD Anderson, which looked at outcomes after EPP and IMRT for malignant pleural mesothelioma. 100 patients with EPP, a good number. 63 patients had IMRT in the adjuvant setting. Usually a lot of them did not have chemotherapy. Right-sided, about 66%. A third of them had non-epithelioid histology. And most of these patients were actually quite advanced, so looking at 72% had stage 3 and 15% had stage 4. But their median overall survival was about 14 months. But again, a lot of these were very advanced. Their local recurrence rate was only 13%, and obviously their distant rate was about 50%. And that's consistent with a lot of what other people have presented thus far. There was some dose-dependent pulmonary toxicity after postoperative IMRT. About the same 63 patients that had IMRT as the prior study they looked at, and it had 37% died within 6 months of IMRT and 7 of other non-cancer causes. So we're not really hitting a lot of home runs here. On multivariate analysis, only the V20 was predictive of death. And so if you had a V20 greater than 7%, you had a 42-fold increased risk of death. And so what I usually tell those people that are doing IMRTs, you just need to be really careful. I think another study that kind of pops to my mind when I think about that is Aaron Allen's study from Harvard. When he looked at that, and there was some fatal pneumonitis that was associated with IMRT for mesothelioma. He looked at, basically presented a kind of an urgent study that came out in 2006 that had 13 patients that were treated to 54 grade 1.8 grade fractions. Most of those patients had inter-op cisplatin, and then 10 had adjuvant cis and pemetrexed after EPP, but before RT. The contralateral lung was limited to V20 less than 20%. We know that for those that aren't radiation oncologists, we typically, in the intact setting, limit it to 37%. The mean lung dose was 15 gray, and about half the patients actually developed fatal pneumonitis after treatment. And that median time to pneumonitis was just 30 days, so pretty quick in terms of those patients that did pass away. And I think a lot of that was because there was a lot of low dose that went into the contralateral lung, and so there was a lot of red flags that were raised, and we've been very careful and cautious since then as we've kind of moved forward with this. Your median V20, mean lung dose, and V5 for those patients that developed pneumonitis was about 17%, mean lung dose of 15, and a V5 of 98.6. And so as compared to those patients that didn't actually pass away, where you are almost half, so about 10% for V20, 12.9 for the mean lung dose, and 90% for the V5 for those that didn't develop the pneumonitis. So I think we do need to, this was kind of a cautionary tale. Granted, this was back in 2006, that I think as we've kind of moved forward, we've been very careful. So what is the data supporting the use of RT with intact lung? I think I think the Memorial study, which a lot of people have already quoted today, which looked at 36 patients with 2 intact lungs that were treated with pleural IMRT to the hemithorax. Their median dose in that was just 46.8 gray. Most of those were right-sided tumors, but it was pretty split. Epithelial was 3/4 of them had epithelial tumors. Again, most of these were pretty well split and had higher stages. So over 66% had stage 3 and 4, and 32 patients received induction chemotherapy, so almost all of them. And 56 underwent a PD before IMRT. They had 20% of them had grade 3 or worse pneumonitis, 2 had grade 3, and 30 patients were accessible for late toxicities. In the surgery group, the 1 and 2 year overall survival was 75% and 53%. Your median survival was 26 months. For those patients that didn't have surgery, you had 69% and 28%, and your median survival was just 17 months. So let's switch gears and talk a little bit about proton therapy. And a lot of this information that I've gotten has actually come out of MD Anderson because they've started doing some of the initial work, but it is very, very early. The two studies that kind of have predated that came out in 2010 and 2012, but they've really only looked at dosimetric considerations that have shown that there is specific sparing of organs at risk. That's what OAR stands for, with the improvement of coverage. The V95 was actually just 1.6% larger in those studies. When you look at the normal tissue complication probability, it did get reduced for the liver, it was reduced for the esophagus and the ipsilateral kidney, but these are just some of the examples that they showed. So MD Anderson just recently published on this, and they described their clinical implementations for IMPT for lung intact malignant pleural mesothelioma, and I don't think the paper is actually out. They're have just submitted and I think it just got accepted, is what Dan Gomez told me. And they performed dosimetric comparisons for initial patient selection recommendations, and they gave 45 gray and 25 fractions to the PTV and 60 gray and 25 fractions using a simulated integrated boost. Their target definitions are a little different than what we've done in the past, and it is thinking a little bit outside the box as opposed to treating the entire hemithoracic cavity. And again, I think that all of us in the radiation field are kind of looking, well, how do we need to kind of slice and dice this and look at this a little bit differently? Because, as we've seen from some of the data that's been presented today, it's not a one solution for everything. And so they did for the GTV, it was the gross disease on the PET and CT scan. The CTV was the external pleural surface. And then they just did a 5 to 10 millimeter margin around the GTV. The field still ended up being pretty big, and I'll show you an example of that in a second. They analyzed 7 patients that had lung intact, patients treated with IMPT versus IMRT, and they were replanned with the other modalities. So 4 of these patients had IMPT originally, 3 had IMRT, and so they switched it to see, well, what's the benefit of, what if we switched it? What if we'd done this with IMPT, or what if we had done this with IMRT? And again, it was just kind of look at dosimetric changes. And you can kind of see what those fields look like. And they did a 4-field plan using an AP, a PA, a left P, and a left A, looking at 2 oblique angles. And so we're treating kind of that entire area, but it doesn't extend all the way as far as we normally have treated with our hemithoracic radiation therapy. It did take about 45 minutes to treat. About half that time was actually just the setup, and then the last 4 fields were treated within 25 minutes. And this was after they had kind of worked on this. Originally, I think it was about an hour and a half that they were using to treat each patient, which is exceptionally long. Typically, for those that don't know, we can treat a conventional radiation therapy patient in about 15 minutes. And so this obviously takes a lot longer, and there's a lot more setup that's involved. They did optimize it with 4 fields. The QA process, to QA this, usually it takes a few hours. In this case, initially it took 8 hours with extensive phantom measurements. They did reduce it to about 3 hours after gaining some experience. And what they found with that is the things that were improved using IMPT as opposed to IMRT is the total lung mean dose went down, the total lung V20 went down, the total lung V5 went down, but nothing on the ipsilateral side actually ended up being significant. The contralateral lung mean dose is really where you had a lot of your savings, both in the V5 and the mean lung dose, and that's what they found to be significant. And so, and this is kind of looking at a kind of plan, looking at the IMPT, and you can see where their high dose was kind of around the edges, and then it kind of falls off. There's a little bit of a cool spot in the middle, though they really aren't saving too much in that case. So from a dosimetric standpoint, they've determined that the patients that do better with IMRT are those that have low functioning ipsilateral lung, because that way you can spare the higher functioning contralateral lung. If you have mediastinal nodal involvement, inferior gross disease, so you can, if you want to spare the liver or the kidney, they were able to kind of save those. And then if you had left-sided disease, like gross disease that was adjacent to the heart. The patients, they thought that would be less beneficial, so those that they typically give with IMRT, they're looking at those that had large ipsilateral lung tumors, no gross disease, and high-functioning ipsilateral lungs, because that way they wouldn't impact that as well. And so they've been treating those patients with IMRT. There is no overall survival, median survival, or progression-free survival. It's just too early, and there's just too few patients to kind of look at that. So what they found is that IMPT is feasible. You can reduce the dose, like I said, to the contralateral lung, the heart, the esophagus, the liver, and the ipsilateral kidney with IMPT. Like I said, the ideal candidates are those with gross disease, but there's obviously additional study that's needed to determine whether these dosimetric benefits actually translate into any kind of clinical benefit. Are we still having the same control rates? Are we still, just because we're seeing the pretty pictures on the paper, does it really translate into real life? So let's switch gears and look at, well, what happens when you use neutron therapy? Like I said, neutron therapy is used in the kind of the radio-resistant setting, like sarcomas. Adenoid cystics have been shown to be really beneficial. And so this study came out just a couple months ago, and looking at our experience, and it's about 30 patients that were treated with neutron therapy. The median age was about 60. 50% had Brigham stage 1. About half of them were epithelioid histology. 73% had EPP, and median dose was 18 neutron gray. So, but like I said, that 18 neutron gray is about 8-fold very effective in terms of when you look at the relative biologic experience. Of those patients, 15 had local recurrences and 3 had distant disease, so a little different kind of in terms of efficacy, because we typically have seen that these patients fail distantly. The median overall survival is just 20 months. And so when you looked at this, this is survival by treatment modality, looking at trimodality versus just radiation therapy or surgery by itself. And there really wasn't any significant difference. Actually, the p-value was not significant. The median overall survival was 22 months versus 16 months. By Brigham stage, it did kind of split out. That's not surprising. And so we just very recently, in the last 2 weeks, this is kind of hot off the presses, decided, well, let's kind of look at our overall experience in terms of photon therapy, in terms of neutron therapy, et cetera. So we expanded the search a little bit and then actually excluded a number of the early neutron patients because we realized that a lot of those were planned kind of with using very different techniques, not the typical hemithoracic radiation, and they didn't really get the dose where we wanted it to. So we looked from 2000 to 2015, and had 68 of those patients received chemotherapy, majority, 62% received radiation therapy, and over time we've become much more selective as to which patients end up coming to see me for radiation therapy. It's those patients that typically over time have had the epithelioid histology, those that are early stage, and so we've become more selective, and we're hoping that we're not under-treating those patients that have sarcomatoid, but I think we do need to kind of think a little bit outside the box. 35 patients, about half received all 3 modalities. Your overall survival by AJCC stage, those patients that had an earlier stage did much better than those that didn't. When you look at radiation therapy, we had a median survival of about 20 months for those that did, and 9 months, that did not get radiation therapy with a hazard ratio of 0.41. When we looked at, in terms of whether you got photon therapy or neutron therapy, it was kind of a wash, actually. Our hazard ratio is 1.2 and p-value is 0.52. And we're looking a little bit more into those numbers to see, well, really, were the patients treated, how were each of the patients treated, and, were they treated in different eras. In terms of chemotherapy, we actually looked at that to see if giving chemotherapy did it make a difference in our patient population, and there was a hazard ratio of 0.32, and you can see that the curves are nicely separate for those that got chemo versus those that didn't, with a p-value of 0.03. Trimodality also did fall out with a hazard ratio of 0.45. Those that got trimodality did better than those that didn't. Your median overall survival was 14.6 months versus 8.6 months. So kind of the takeaway is kind of a little bit like looking back at all of this, because we've talked about photons, we've talked about protons, we've talked about neutrons, and you've heard from a number of other speakers. When you look at the studies that are out there, and these are kind of just the general ranges, you're seeing that we're really not getting much beyond the 2-year overall survival mark. And so, I do think that we need to kind of look to figure out which patients are ultimately going to benefit from this trimodality, which patients should we be super aggressive. And clearly there's a lot more work that needs to be done to improve outcomes. So I have a great team that I work with. We have a number of surgeons that are up there. There's 3 of us that do radiation oncology at the University of Washington that treat these patients, a slew of medical oncologists, pulmonologists, radiologists, and nuclear medicine. And I'm very appreciative of the work that they do, because obviously we work very much hand in hand to make sure we're giving the patients the most appropriate treatment. So happy to take any questions. So.